Good morning, everybody. How is everyone? You can nod. I've just got a quick question actually for everybody who's attending. Has anybody using apomorphine therapy, if they can nod or let Cassie know? Cassie, anybody waving, shaking?
We've got a couple there.
Yes? Okay, that's cool. Great. Okay, so let's go through then. So this is one of, we'll start off with this as one of 3 of the device-assisted therapies talks. So you may be aware that with device-assisted therapies, when we talk about them, we're talking about the drug apomorphine and duodopa and deep brain stimulation. So we'll kick off on what is considered probably the least invasive of the device-assisted therapies. And so I guess addressing a panel such as yourselves, I guess the questions would be, why would you consider using apomorphine? What is apomorphine? How is it administered? What are the benefits? What are the risks? And then we can have some time for questions and answers. And I'd really love to hear from the people who have apomorphine at the end as well. When I was working at St Vincent's Hospital in 2009, I think apomorphine was one of the first device-assisted therapies that I had been involved in. So it was pretty exciting times for me there, and I learned a lot about how to initiate and start apomorphine with Dr. Tish and Dr. Bolitho. So just, you know, I know that this is like preaching to the converted, but we know that Parkinson's disease is a progressive neurodegenerative disease, and it's caused by these loss of dopaminergic cells in the basal ganglia, and we know that dopamine is required for normal movement. We also know that despite much research, we still don't know why these cells die off. And there's no cure to date. And so the gold standard of treatment is always to treat the symptoms. And I put that in the background because that explains perhaps, you know, this progression of this disease. And then at what point will we need to consider someone using one of the device-assisted therapies like apomorphine. And just if you notice down here, we know with in the substantia nigra that there's this neuromelatonin, and it's sort of very dark in people that don't have Parkinson's, but people that have Parkinson's, there's a loss of this neuromelatonin. I saw this slide some time ago that Dr. Silberstein presented at a talk, and I think it's a really, really important slide. So if you go back and you know the pathophysiology, then you look at, you know, how this Parkinson's disease progresses, and we talk about the preclinical phase, which could be between 5 to 10 years, where things are happening and we don't know until we get that aha, you know, moment when people have lost 60 to 80% of dopamine cells. They go off to the GP with symptoms, and then typically they start patients off on levodopa therapies or dopaminergic therapies to replace what's missing. If people are a bit younger, they might decide to use a dopamine agonist. And the reason of that is, as we know, as you continue to take levodopa in the form of Parkinson or Matapar, the disease progresses and the therapeutic window of these tablets start to wear off at a certain point. And so when people would take tablets, say maybe 3 times a day, it's, you know, 6, 11 and 4, they're finding that maybe they're starting to get to this wearing off point. And so they go back to the neurologist and he says, add in another tablet, or let's add in something else. This disease, and these timeframes are very arbitrary because, as we know, people progress very differently. But then we start looking at motor complications. So there's wearing off, there might be some unpredictable offs, there might be dyskinesia where people, and you know, where things are starting to change a bit with their disease. So I guess it's this part here that we might start to think about alternatives to this oral levodopa therapy. I'm not sure what you can see here at the moment. Do you have why do these things happen? It's just back to this progressive, insidious, degenerative nature. So, you know, even though you might be taking oral therapy, those dopamine cells are still dying off. And then that can be result in this wearing off or unpredictable motor fluctuations and dyskinesia. And then in addition to that, there's a lot of, I'm not sure if you can see this, Cassie, the gastrointestinal, there's a lot of research about how the word's actually called gastroparesis. It's just a slowing down of your gut and the ability to actually absorb the medications. And so lots of studies about how this becomes a bit erratic and a bit dysfunctional as the disease progresses. And might I add in, constipation, oral therapy can be a bit tricky. Does that resonate with everybody? People understand that, I hope. So here's a story of a fellow that I was looking after in Fredericton. He was a 67-year-old man and he was on a regime of Stalevo. And so for those who have never had Stalevo actually has levodopa and carbidopa, just like Kinson, but we add in an extra drug called Comtam, which is the 200 milligrams here. And so the Comtam is actually to try and help prolong, the levodopa response as this man's disease had progressed. He'd had it for about 10 years. And he was actually taking his Stalevo, which is a fairly significant dose, every 3 hours. So at 6 in the morning when he woke up, 9, 12, 3, 6 and 9 o'clock at night. He also had a Nupro patch or reticotine, and that class is also a class of dopamine agonist drugs. And then recently he'd been on Azilect or Resigaline, another drug, an MAOB inhibitor, which is also to help prolong out that levodopa response. And he'd been changed over to another drug that you might have heard of or you're on yourselves called Xadago. He was progressing. He was having issues with constipation. So I figured he must be having very slow gastric motility and this erratic gastric emptying. And so when he was taking his Stalevo at 6 o'clock in the morning, he was finding that he wasn't coming on. He wasn't getting an on phase. He'd try to take the 9 o'clock a bit earlier, and he still wasn't coming on. And then all of a sudden he was coming on and he was very dyskinetic. So he wasn't having a really good response to his oral therapy. And he sort of fits in with this stage of his journey where despite optimizing his oral pharmacological therapy, like adding in these extra agents, he still wasn't getting a good response. So he was getting motor complications. He was having lots of freezing of gait, which was very debilitating. He was having fairly unpredictable medications off. So he'd be walking along and feeling okay. And then suddenly he had a few falls, things weren't going so well, but importantly, he was having these really delayed times to get to a medication on. He didn't have so much dyskinesia, he did at times. So what would happen if he'd taken the 6 o'clock dose and the 9 o'clock dose and then suddenly they were being absorbed, he might have got a big hit of levodopa and he was getting quite dyskinetic. So the idea then is that at this stage of this person's journey, do we consider a drug delivery that aims at sort of continuous dopaminergic stimulation and you bypass having to take the tablets because there's issues associated around with that? Everyone with me? Please tell me if my daughters say that I'm a smarty pants and I use big words and I should slow down and talk, what they can understand. So let me know. You guys have got Parkinson, so I'm hoping you'll be in. So this man, I met this fellow and I thought he was living alone as well. And I thought, you know what, I reckon this guy would go really well on apomorphine. Okay, he was living alone. It was the least invasive of these 3 device-assisted therapies. When I said to him, what about apomorphine? He went, oh my God, is that an opiate? Is that like morphine? And can I just say it is not an opiate, okay? It's actually a dopamine agonist in the same class as your reticotine and cifrol drugs. They call it non-ergolone, and it actually works on dopamine receptors. So instead of being dopamine and levodopa getting converted, it actually attaches to I think the D3, D4 receptors in the brain, and it mimics it. So it says we've got dopamine happening now. I looked back into the databases. Actually, Vince, Carol and I were doing a big project on looking for adverse events of apomorphine and discovered in 1868 Matheson and Wright synthesized this apomorphine hydrochloride by boiling morphine and hydrochloric acid together, and that's how they got apomorphine. But also noted back even into ancient Egypt that they were using it for shamanic rituals, and also for the treatment of erectile dysfunction. So it's been around and it's been coming in and out of flavour. But I still think it has a great role for people with Parkinson's. So initially, I guess it's a decision with your neurologist to proceed down the track of apomorphine. For the very nature of why we want to bypass taking tablets, it does have a very limited oral bioavailability, which means if you take it, that percentage of drug doesn't get in your system, it gets passed out through the liver. So it is given as a subcutaneous injection or a subcutaneous infusion. Do you know, and are you happy with it when I'm saying that? So it's usually an injection into the fatty layers of your tummy, not a deep muscular injection, and it's not given as an intravenous infusion. So it's usually started in a hospital setting and typically in a body movement clinic. Although a lot with bed shortages and so many things happening in our hospitals, we actually initiated a lot of the pre-apomorphine therapy for people in the community at home, and I'll talk about that. So this man also, he was also really keen for deep brain stimulation, and we figured that this would be a really good bridging therapy for his DBS. Getting the patient ready. Apomorphine is actually used in small quantities by the vet, in case you're wondering, to make dogs throw up if they've swallowed something that's toxic, dogs and cats. So it does make people very sick, and I've actually worked with a few neurologists who haven't started off a medication called domperidone, and they said they'll be right. And I went, watch them get the vomit bowl, I'm sure they'll vomit. So we do start patients off on this drug called domperidone, which, you know, if you've got Parkinson's, would be the most useful drug for people who are feeling nauseated. And we do it, what we say, prophylactically. So we give it 10 milligrams, 1 tablet, 3 times a day before they start on apomorphine. We also check, just by the way, you know that I think domperidone sounds like a really classy champagne, so you'll never forget the name of it, or Motelium. We also do an ECG. We do a tracing of your heart, because the drugs domperidone and apomorphine can sometimes prolong what we call this QT interval. And this was a study that Vince and I were doing. We went back through all the databases to see how many times that occurred and whether that was a risk. And we didn't actually find we didn't find many really good randomized controlled trials that were looking at it, but reports of it were very minimal. We also check people's bloods, and we do a test, including in those full blood counts, called a Coombs test. And that's because there has been some reports about what we call hemolytic anemia in patients. So we just monitor that. And so far, all the patients I've had have been very safe, but we still check that. Most levodopa or dopamine agents, these can cause a little bit of postural hypertension. So we also check people's lying and standing blood pressures before we start the therapy. And then we look for any allergies. And believe it or not, if you are allergic to morphine, then it is a contraindication. And we certainly make sure that when we're talking to people about apomorphine, that we speak to family members. And I'll tell you a really cute story at the end about what happened when this other man in Sydney didn't have a family member. Are you still with me, everyone? Yeah, all good. All righty. So there are options when we commence apomorphine. And I'll go back to this fellow that was up in Port Macquarie. When I remember, I said that he would take his Stalevo, his 6 o'clock and then his 9 o'clock dose, and he just simply wasn't coming on. So what we did was we said, why don't we give you what's called a rescue injection? So he would still take his tablet at 6 o'clock in the morning, and then he would use, it looks like a little diabetic pen, and I actually thought I had one, but I can't find it anywhere, but it just looks like a pen, and I'll show you a picture of it. And so he would load up this pen and put a little needle on it, and he would give himself an injection. And within about 5 or 10 minutes, he was actually on, and he would be good. He would be able to get up and get to the toilet and start to prepare his breakfast and so on. But it wears off quickly as well. By that stage, then his oral medications, he said, would come on. And that worked really, really well for him. After a period of time, I realized that he was using the rescue pen throughout the day, which was fine. We were very happy for him to use that. And he was using up to about 4 or 5 times a day. And I said to him, instead of having 4 or 5 injections a day that you've got to do yourself, what about 1 injection and we attach you to a pump? So that's the other option. So we set people up to an infusion pump, and it's what we call a continuous subcutaneous infusion. So it's just going into that subcutaneous tissue via a needle. Most patients I've looked after have had a subcutaneous infusion of the apomorphine via a pump while they're awake. So they put it on at 7 o'clock in the morning and take it off when they go to bed. There's a couple of people, though, who've kept the pump running overnight. And it's usually people that live alone who find it really difficult to get up the next day and actually assemble all these pump and pieces and needles. So there's lots of options. There's 2 companies in Australia that provide apomorphine. Some people in the group may be on a drug called levodopa. It's all called apomorphine. It's just marketed differently. And so they use this pump. You can see the pump here. I think it's called a chrono-apopar pump, and it gets preset. So what might happen if people come into hospital for this option is that we sadly take them off their medications the night before, and we see them at their worst, and we get them to do, all the tests that we do, and it's called the UPDRS, and we do a score when they're off, and then we give little bits of the apomorphine. So we do like 1.5 milligrams, and then we repeat these scores and see if they improve, and then 3 milligrams, and then we repeat the scores again, and then at these intervals. And then we work out, that gives us a point to work out what would be a starting dose that we can pre-program into the pump and set it up for the patient. Typically, they might continue to take their oral medications, and then over a period of time, those oral medications might start to wane down, which is what we did with this fellow in Port Macquarie. The other company that supplies the drug is a Pfizer company. You've heard of Pfizer. Everyone knows who Pfizer is. Their drug is called Apomorphine, and they have a pump. And I've actually got a demonstration model here of it. People say to me, "How does it all work?" So can you see this is the actual apomorphine, which is clearly out of date. It's a clear liquid. And what happens is that the patient puts the clear liquid into this, it's called a cassette. Can you see this? All right. Okay. I'm doing it all the wrong way. And if Pfizer saw me, they'd be horrified. There's actually all these little holders and stands for this to happen. That fills up the chamber. The chamber goes into a pump that's been pre-programmed as well, like this. And then they attach a needle, There's the company, and I'll talk about this too, the company supply a lot of these consumable products, both the companies do. This attaches to here. I'm not doing it completely properly, but anyway, if you can see, and there's the little needle at the end that goes, it's like a little thumbtack. And that goes into your tummy, and you've got to put that in, rotate it around and secure it. The way, and so instead of taking people off their medications in a hospital setting, there's been another trend where you may come in and into a hospital setting, and we might do a very gentle upward titration. So it's not that barbaric taking off medications. And so you start on your medications, and then we use the pen and see what the responses are. And I'm not sure, I've been out of the hospital system for a while, but there was certainly lots of discussion about that. These are the pens. So if you can see, this is a starter product. So you can see it looks like a diabetic pen. If anyone's ever seen a diabetic pen, it uses the same needles. These get loaded, and I think the actual pen gets discarded after 48 hours. This is the D-Mind pen that Pfizer supplies, and I wished I had a copy of a pen so I could show you. There's a little cartridge that goes inside that, and then you just dial up, the end, and then you attach the needle, and away you go with the injection. So it's pretty easy to use. Having said that, you know, Parkinson's is a tricky disease, isn't it? And you're trying to use fine motor skills to give yourself an injection. It's always good to have someone around to help. So the benefits, I think particularly most of the benefits of apomorphine is probably the reduction of the number and of episodes and the severity of the off phases, particularly with this fellow that I looked after. So he really got a lot of benefit from these unpredictable wearing offs, improvement in wearing off and less unpredictable off times. And I guess a lot of people's feedback said when we saw them follow up that if they knew that they knew that they had a really good supply of dopamine, that led to them to much more increased confidence to participate in normal activities. So if they were worried about leaving home and they were worried about what's going to happen, they said that once they're on the pump, and they had a great lot of confidence to get out and do things. And I think one of the most beautiful stories was a lady I looked after at St. Vincent's, and all she wanted to do was wash her car with her granddaughter. And that was her goal. And so she rang up not long after she went on to apomorphine to say that she was really excited. She bought a new car, and secondly, she was able to wash it with her granddaughter. So that was a really, I mean, it sounds simple, but it was really lovely. Adverse events. So I guess everybody wants to know what they are. So it can cause nausea, hence the domperidone. It can cause a bit of hypotonia. There is a lot of discussion about it can cause inflammation at the injection sites, and that can actually can cause skin nodules as well. So it's little lumps that are under the skin, and that could possibly be a reason why people might discontinue those. But most people, you know, they use the ABC sign, and they make sure that every day they put the needle in a different spot to reduce the risk of those skin nodules. And falling asleep makes people a bit sleepy, but they get very used to the drug, just much like levodopa, and it works well. We also have to always watch out for impulse control disorders, particularly with any of these dopamine agonists. So, you know, we talk about the 4 horsemen, hypersexuality, you know, gambling, shopping, punding, binging, and so on. And they're closely monitored with people as well. Sometimes orthostatic hypertension, so people's blood pressures can drop with introducing these medications. So we watch that very closely as well. There was one study that I looked at by these authors in, I'm pretty sure they were in the Netherlands, and they did a study of 45 patients who did have cognition impairment and visual hallucinations before they started using apomorphine. And their study said that the apomorphine was very well tolerated in people with cognition impairment and visual hallucinations. But what I really, really liked, and this actually happened to me, that 80% of patients who were actually heading towards a nursing home placement returned to their homes. So once commencing that therapy. So, you know, I've advocated, I think it's great, and it certainly is a bit of a game changer. I said to you before, there was a little pearl of a story. There was another very cute man that I looked at. Everyone's cute, but this little cute man, he lived in Sydney. He lived alone in a block of units, and he had these really bad, unpredictable off times as well. He also had the worst temperature dysregulation. So even though we'd get him and help him with a shower, and he'd sit underneath an air conditioner, he would just absolutely diaphoretic and sweating, and we'd have to pop him back in the shower again. But anyway, he was put onto apomorphine, and it was back in the days when people actually had to draw up using a needle and a syringe, and the ampules looked a lot different. Anyway, his landlord was like the Incredible Hulk. He was a former carpenter, and he said that he would help this man set up his apomorphine in the morning. And so I spent a lot of time with education on the ampule, and every time he held this ampule, he would crush it into shards of glass. And I said, oh my God, you're just way too strong. And so we couldn't use him. But what this landlord did was he said to another tenant who just recently lost her job, he would reduce her rent in exchange for her to help set up the pump. And it was, so that worked very well. So it was a very cute story. The costs, you know, the pumps and the pens are provided by the pharmaceutical companies. Apomorphine is actually called a schedule or specialised. It's called the S100, so it needs special approval for it to be prescribed, usually by a neurologist. With the apomorphine, if a neurologist has prescribed it once, then your GP can actually re-prescribe it if you run out. Both services have really amazing nursing follow-up services. So Pfizer has an answer service nurse, and they're amazing. And also Starter have amazing nurse follow-up too, and they come and check you in your homes and see how you're getting along. They're really excellent services, so you're never alone. They supply both. I'm not sure what's started, but I know that they supply a backpack full of infusion lines, which are usually the older style butterflies, dressings, creams, needle disposal containers. And some people who actually prefer to use this, you can see this, the Neria. Neria is a lovely, nice, easy infusion line. They're a bit more expensive, but I know that with the chap in Port Macquarie, we actually paid for some of these consumables using his My Aged Care package, or using NDIS. So pretty good service